This is part 2 of E and M coding for interventional radiologists. This covers the outpatient component. This is brand new content covering the updates that took effect January 1st, 2021. Couple basics about the 2021 changes, which in my opinion are significant, and they really simplify E and M coding from an outpatient perspective. So currently these changes apply only to outpatient office visits. These went into effect January 1st, 2021. The big change is history and exam are no longer used to level a note. Service is leveled based on time or medical decision making. A new medical decision making table has been made, which really simplifies things for the practicing interventional radiologist. In the old system for medical decision making, you had to factor in problem points / diagnoses, data points, and risk. And risk in its own had a very complex chart. We will go over the new medical decision making table, but it is a single chart that you have to reference to level these notes. Work RVUs were also increased, which is significant, as I think this will bleed over onto the inpatient side in the future. Also, new 99417 or G2212 codes were made for prolonged services, and we'll briefly touch on those. When we look at the time-based billing updates, again, it's either, when you level the note, it's either going to be based on time or medical decision making. Again, just like on my inpatient video, most of these encounters, it will be more efficient for you to go component-based billing based on medical decision making. But there have been significant improvements in the way time is counted. So when we look at the old guidelines, that time had to be face-to-face, and half of that time had to be spent on counseling and coordination of care. Those guidelines were thrown in the dumpster. The new guidelines, there is no counseling or coordination of care required because most of E and M isn't centered around counseling. What this does include, this includes all face-to-face time on the day of the encounter, and it also includes non-face-to-face time before and after the visit on the day of the exam. So it's all inclusive. Let's say I'm seeing a patient in the office and I take 10 minutes to review their chart. I see them in the exam room for 15 minutes, and then I spend 15 minutes after the fact working on a note, making phone calls. All of that factors into time-based billing in the outpatient setting. And so it really has simplified E and M coding. A little bit about prolonged services. Medicare will only pay for the G2212 code, and then non-Medicare people, it's 99417. When we look at either new patient encounters or established patient encounters, these are going to be coded in 15-minute intervals above and beyond whatever the top end code is. So for example, for new office visits, 75 minutes is the max time for a level 5. So let's say you spent 90 minutes, you would bill 99215 plus G2212. For established patient codes, these kick in at 55 minutes. The work RVU values for G2212 or 99417 is 0.61. And again, these codes are used on top of 99205 for new patients and 99215 for established patients. For the medical decision-making update, there is a new table for medical decision-making determination, and 4 levels of medical decision-making remain. You have straightforward, low complexity, moderate complexity, and high complexity. Here's the AMA chart. Here's kind of a global view. It's a lot to go over. But again, if you notice the chart, we have straightforward complexity, low complexity, moderate, and high. And there are 3 different categories of the medical decision making, but this is the only chart that we will use to level the medical decision making. So you have number and or complexity of problems addressed, you have amount and or complexity of data, and you have risk. So it very much mirrors the old system. It's just a simplified version. So when I'm calculating medical decision making, I look at problems or diagnoses, I look at data, and I look at risk. When we look at the risk column to the far right, that is unchanged for the most part from prior the old system. And when we look on the far left, we look at number of problems or diagnoses. That again is unchanged. The huge change comes in this middle column when it talks about amount and or complexity of data. So that has been significantly updated and has become much more physician friendly. As we move forward in this talk, I will break down each of these medical decision making levels and we'll get more specific. Here are the first of the 4 categories. And again, when we look at interventional radiology patients, we deal with very sick patients, a very critically ill patient population. So most of our medical decision making is going to live in the 3rd category. But this straightforward category is 99202, 99212, really has minimal requirements. You have to have 2 out of the 3 medical decision making elements to qualify. So really from an interventional radiology perspective, none of your patients are going to fall into this criteria. Now we're moving on to low medical decision making, and this factors into the 2nd category that we have for new patients, or the 3rd category, the middle category we have for established office patients and follow-up. And again, we only need 2 of the 3. So if you think about it, problems, data, and risk. Really, problems are easy to get. You need 2 or more self-limited or minor problems, 1 stable chronic illness. When you look at interventional radiology patients, most of our patients have multiple stable chronic illness. So it's very easy in the problem chart to get to this category. If we look at data review, you only need 2 of the following in category 1. If you review an old note, that's a point. And if you review old notes from 2 different sources, like let's say one's from a cardiologist and one's from a nephrologist, then those would be in addition, right? 1 for the nephrologist, 1 for the cardiologist. So that's 2 points there. If you review any lab imaging, any lab results or imaging results, that's a point. So each result of each unique test. And then if you ordered a test, that's a point. So again, most of our patients are going to be a little bit more complex than this low medical decision making. Where I find most of my patients in the outpatient setting fall is this moderate medical decision making, which just would end up being 99204, which we'll go over. That's a new patient, 3rd category out of 4, and then 99214, which is a 4th category out of 5, so kind of a level 4 out of 5. And when we look, we only need 2 out of the 3 medical decision-making elements to qualify. And again, this is very, very simple compared to the old system. So I either need time or medical decision-making, and on my medical decision-making, I only need 2 of these 3 things, some of which are very easy to get. So we look at problems. I have all these combinations of problems that I can get the points for. So 2 or more stable chronic illnesses, that qualifies for problems for moderate medical decision making. Well, that's almost every single IR patient. So then I either need to look at data or risk. Moderate risk of morbidity from additional diagnostic testing or treatment, that's up to the interpretation of the physician. And then we look at data. So let's just look at category 1, okay? So I need 3 of the following. So if I review a note from, let's say it's a UFI consult, first time seeing him. I review a note from the OBGYN, that's a point. I review labs, let's say hemoglobin, to see if they're anemic, that's a point. And then I either look at another set of labs from somewhere else or another note from somewhere else, then that's my additional point. If I order a lab, that's a point. If I order any more imaging, that's a point. And one thing that's really going to hit well with the interventional radiologists are, look at category 2. Independent interpretation of tests will get you moderate medical decision making. So every single patient that I see for uterine fibroid embolization evaluation that has an MRI, I can say MRI images were independently reviewed, which show X, Y, and Z. And so my independent interpretation of that MRI, which is separate from how, the original interpretation, would qualify me for moderate medical decision making. So for your interventional radiologist who's seen patients in consult, if you review any outside imaging and render an independent interpretation in the note, you're automatically moderate medical decision making. And again, I say that I independently interpreted the CT from whenever or the MRI from whenever, and I just give a 2 to 3 line sentence on my, 2 to 3 sentences on what I think I see. that qualifies me on the data side. So it really simplifies things for the interventional radiologist. And high medical decision making, which would be the highest new inpatient encounter versus your highest inpatient follow-up. Really, this is for, let's say you're a family medicine doctor, some guy comes in your office and is having angina, and they're just not doing very well. I don't see a lot of scenarios where the interventional radiologist is going to be billing this level of care. But you need two of the three. You would need problem-wise, one or more chronic illnesses with severe exacerbation. Maybe you got a post-haste patient that needs to be admitted for hydration, is not doing very well. On the data side, you need two of the three categories. So you would need 3 from category 1, and you would probably need category 2. So from an IR perspective, you could get there, And then high risk of morbidity from additional diagnostic testing or treatment. Now, after looking at the 4 categories of medical decision making, we'll look at the changes that were made. So we're going to start with the old outpatient new office encounter setup. So this is what it used to look like, 99201 through 99205. You had to have history exam and medical decision making, and then you had time and RVUs. We know that we updated time. We know that we upped the RVUs on some of these codes, and then we got rid of history and exam. The first thing they did was they got rid of 99201. They found that nobody really was billing that code, so less than 1% of the time if a patient came into the clinic was that being billed. So if nobody's going to bill it, just get rid of it. So we're left with 4 new outpatient office visits. So one good question is, hey, is my patient considered a new outpatient or is it established? Well, if your patient has been seen by somebody in your specialty with your group in the past 3 years, they're considered established. If they haven't been seen in 3 years, then they're a new patient. So now we have 4 categories for a new outpatient encounter. We've gotten rid of the history and the exam component, and we've deemed it's whatever is medically appropriate that needs to be documented for the history exam. So it leaves it up to the clinician to put what they think is necessary. So the driving factors, again, are now medical decision-making and time. When we look at the old time for these codes, those are the breakdowns, and we switched them to ranges, right? So like 99204, which is a very common code that I would bill, went from 45 minutes to 45 minutes to 59 minutes. So those are the old times in the old system, and then the new times are over to the right. Let's look at RVUs. So for 99202, it's the same. But if you look at a 99204, it went from 2.43 to 2.6. So I think that's a significant bump in type of environment where a lot of work RVUs are going down. We are increasing these E and M codes. So again, please download the handbook. It's free. I want everybody to have it. I want everybody to use it. You'll find this chart in your handbook. It's the outpatient office new encounter chart. And again, it's very simple compared to the old system. It's either the medical decision making or time drive the visit. Most of our patients, or most of what I bill, a huge percentage is 99204. Because if you look at the medical decision making criteria, which we've already covered, most of our patients fall in that moderate category. Now let's take a look at the changes that were made for established patients. And again, an established patient is somebody that's been seen by somebody in your group or specialty in the past 3 years. So that, somebody in your group or yourself. So again, we got rid of history and exam, and it's down to medical decision making or time. So let's see how they changed time. So old times, example 99214 is a pretty common follow-up for me. It went from 25 minutes to 30 to 39 minutes. And again, with all this coding, if I have moderate medical decision making, but I only spend 10 minutes with the patient, it's still a 99214 based on medical decision making. The really only time that I bill time is, let's say I end up spending 60 minutes with the patient in follow-up, and I talk about de-escalation of care or hospice. Let's say they're an HCC patient who's just not doing very well. Well, if I bill 60 minutes, then I'm going to end up billing the 99215, even though my medical decision making was moderate. But otherwise, everything I bill is just going to be based on medical decision making. We look at RVUs. There was a good bump in work RVUs. So again, 99214 is the code that I bill the most common, moderate medical decision making. RVUS went from 1.5 to 1.92. Reference the handbook. This is the chart that you're going to have. So again, there's 5 codes left, and either medical decision making or time will drive which code you select. Couple scenarios, and we're going to go through these very quickly. And it's pretty simple with the new system, right? So I have a cryo consult. I do a lot of cryo work. 67-year-old male, hypertension, CKD stage 3, diabetes, and then incidentally found 3.2 centimeter enhancing right renal mass. Well, I can already tell you this is a new patient, and it's going to be moderate medical decision making. So that's going to be a 99204 for me, and it's very easy for me to get there. So if you look at data, I'm going to say I independently reviewed the CT, which showed an enhancing inferior pole, 3.2 centimeter right renal mass, no additional enhancing masses in the kidney. So that automatically qualifies me for moderate medical decision making based on data. And then I'm going to kick over to problems, and all I need is 2 or more stable chronic illnesses. Well, you know, if you have EPIC, you're automatically going to auto-populate all of its problems. And with hypertension and CKD stage 3, those both qualify as stable chronic illnesses. And if this is a new patient to me, again, other things can qualify, but it's fairly simple to see how I can qualify for moderate medical decision making, which gets me a 99204, which is what I think most IRs will see when they see patients in consult, because most of the patients we see have pre-existing medical conditions. We're going to review some imaging, and they've just got a lot of stuff going on. Here's an example of follow-up. So typical RFA follow-up, I'll see them after they get their MRI imaging at 3 months. So 72-year-old male, hep C cirrhosis, ascites, hypertension, stage 2 CKD, status post RFA of a 2.8 centimeter segment 8 HCC, here for a 3-month follow-up. MRI abdomen done this morning. Again, it's going to be at 99214 all day. I'm going to look at the data, and I could probably easily qualify for category 1, but I'm going to slip on down to category 2. I'm going to say I independently reviewed the MRI of the abdomen done X date, and here are my own findings. That gets my data to moderate medical decision making, and then again, I only need 2 of the 3 elements. So I either need risk or problems. So I'm going to kick over to problems, and obviously my patient has 2 or more stable chronic illnesses. So I think these are 2 prime examples of a new patient easily meets moderate medical decision making. You can extrapolate this where you can see a lot of your IR patients are going to be in this category. And again, most of my follow-up patients are going to be the 99214. I will always component-based bill based on moderate medical decision making over time. The only time I'm going to use time is when I feel like I'm spending 70, 75 minutes, 60 minutes on a patient when the medical decision making is only moderate. Thank you for listening to this talk. Please download the handbook. It's free. Use it however you want. Send it to whoever you want. I do not care what you do with it. Number 3, if you like the video, click the like button. If you like the channel, please subscribe. If you have any questions, post them on the comment section, and I'll try to reply so that everybody can see it. If you don't feel comfortable replying on the comment section, feel free to email me individually. My email is ireandm@gmail.com. Again, ireandm@gmail.com.